Good afternoon, everyone. I'm Kaylin Walls, and I'm the president of the Louisville Forum. Welcome to our May 2025 program. The Louisville Forum programs typically meet at noon on the second Wednesday of every month here at Vincenzo's Restaurant in downtown Louisville. All are welcome. Founded in 1984, the Louisville Forum is a nonprofit, nonpartisan public issues group that hosts debates and discussions of contemporary and sometimes controversial public policy issues that impact the greater Louisville community. For more information about the Louisville Forum, our events, to join or to make a reservation, please visit louisvilleforum.org. And now for today's program. Managing Medicaid. Will proposed changes heal or hurt? As we discussed last month, the 2025 legislative session featured several bills which were vetoed by Governor Beshear and ultimately passed after being overridden by the legislature. One of those was House Bill 695. House Bill 695 contemplates several changes to the state's Medicaid program, like mandatory work requirements, as well as the establishment of an oversight and advisory committee. It's estimated that nearly 1.5 million Kentuckians are covered by Medicaid, including 4 out of every 9 Kentucky children. Of that 1.5 million, approximately 200,000 Louisvillians were estimated to be enrolled in Medicaid as of March 2025. Today, we have with us 2 panelists who will discuss House Bill 695, the policies in support of and in opposition to those changes, as well as the impact of these changes may have on Louisvillians enrolled or seeking to enroll in the state's Medicaid program. With us today, our first panelist is Emily Beauregard, the Executive Director of Kentucky Voices for Health. Emily became the Executive Director of KVH in 2015. Under her leadership, KVH has led successful campaigns to get more Kentuckians enrolled in health coverage, protect Medicaid from work reporting requirements and other harmful barriers to care, and build a stronger safety net that meets the basic needs of all Kentuckians. Prior to joining Kentucky Voices for Health, Emily served as the Director of the Planning and Communications at Kentucky Primary Care Association, where she worked on practice improvements, community development, policy advocacy, and communications with members and policymakers. Emily holds a master's degree in public health from the University of Illinois at Chicago. Thank you for joining us today, Emily. Our second panelist is Jim Waters, the president of the Bluegrass Institute for Public Policy Solutions, a free market think tank committed to offering policies based upon the principles of individual liberty and transparent government to expand economic and educational opportunities for all Kentuckians. Jim's writings have been featured in state and national publications, including the Wall Street Journal and USA Today. He's a frequent guest on radio shows, including The Terry Miners Show and the nationally syndicated Lars Larson Show. He has appeared on Fox News and CNN Television, and Jim co-anchors Kentucky Voice Radio and TV shows on Word Media. He's a member of the American Enterprise Institute Leadership Network and a Kentucky Colonel. And last, but certainly not least, today's program will be moderated by a member of the Kentucky Journalism Hall of Fame, Miss Debbie Yetter. Debbie is an independent journalist that contributes to the Kentucky Lantern, an online independent news outlet based in Frankfort, after having previously worked for 38 years for the Courier Journal, where she focused on child welfare and health and human services. She lives in Louisville and has a master's degree in journalism from Northwestern and a bachelor's degree from the University of Louisville. Thank you so much, Debbie and Jim, for being with us today. And with that, I'm going to turn things over to our moderator. Thank you, Debbie.
Thank you. Thank you for that nice introduction. When I first started covering Medicaid in Frankfort years ago, one of my favorite commissioners told me that Medicaid was a true MIGO program. And I'm like, what? My eyes glaze over. It's loaded with facts, figures, and a lot of dense policy discussion, but it is a $20 billion a year program for Kentucky health services. That much goes into hospitals, nursing homes, pharmacies, docs, so it's not an insignificant amount. And about $15 billion of that comes from the federal government. As we are fairly aware, I believe the General Assembly enacted what they call community engagement requirements during the latest session, which require people, able-bodied adults without dependents, who are receiving Medicaid benefits to show that they are working or engaged in some activity such as school or training, and required to report that and show how they're doing it. This is not a new idea. Governor Bevin attempted to implement it during his tenure It was ultimately shot down by the courts, and Andy Bashir, when he succeeded him, suspended it, but now it's back. And it's also being, of course, as we know, debated in Washington, along with many other changes at a higher level that could also significantly impact Kentucky's Medicaid program, along with other states. So with that, I'm going to start with our panelists and ask them, maybe starting with Jim, what's wrong or right about having work requirements, and what would be the impact?
Well, thank you very much, Debbie. It's great to be on the rostrum with a Hall of Famer here. How about that? So really appreciate the invitation to be here today. And it's a good question. I think the title of this forum is, Will Medicaid Reforms Heal or Hurt? I think any serious reforms that actually make a difference in our Medicaid outcomes and cost are going to have to do both. I think that there's going to be some hurt whenever you try to rein in a program that's really exploded in costs. With the Affordable Care Act, we greatly increased, more than doubled our Medicaid rolls here in Kentucky. As Debbie gave the numbers there, 1 in 3 Kentuckians are now on Medicaid, receiving Medicaid. So this program was never meant to be that. It was intended to be for the truly disabled, indigent. It was not meant to be a destination. It was meant to help along the way. And we're concerned that too often that's happened. But I also think it can heal, because I think the dignity of work and people finding a job is important. And I think especially if a person can work and they're able-bodied and they don't have dependents, I think it's very important to understand that the bill that was passed makes a lot of exceptions there. But even with those exceptions, we can save some dollars here on Medicaid. And the reason that is so important is if you want to have a Medicaid program that serves the constituencies for which it was created, resources need to be available to do that. Contrary to maybe what some people think, there is not an automated taxpayer machine there in Frankfurt. I mean, taxpayers are not an endless source of resources. So resources are limited, and they need to be spent in a way that actually help people. And I think it needs to be both. So,
Thanks. Emily?
Yeah, this is such an interesting debate because, as you said, Debbie, this has been going on for at least 10 years now, debating work reporting requirements, debating changes to the Medicaid program that would, perhaps change eligibility, change funding. And we haven't come to a solution that improves health and improves access to care. And I think that what we need to really keep in mind is that the proposals that are on the table, both with House Bill 695 and with what Congress is currently considering with the House's Energy and Commerce Committee plan to cut Medicaid spending, we're only looking at the cost of the program to our government, but we're not looking at the benefits to our economy or to the individuals who are enrolled, to the workforce, to all of the other reasons that we need to have a strong healthcare safety net and we need to be focused on better health outcomes. And so while we do spend a decent amount of money on Medicaid, the cost of being uninsured is much greater. And it's not only greater to the individual, it's greater to our entire economy and to our healthcare system. When you become uninsured, you are going to be delaying care, you're going to be putting off necessary care, rationing your care to the point that your health deteriorates. And if you have an option to get care, you're paying out of pocket and probably accruing medical debt, or you're ending up in the emergency room, and that goes back to the taxpayer. And it puts a great strain on our healthcare system to the point that we know the things that have been proposed would probably close many of our rural hospitals, or at least greatly strain them to the point that we would have less access to care for every Kentuckian, whether you have Medicaid or not. We all rely on the same healthcare system to operate. And so we need our policies to focus first and foremost on improving the health of Kentuckians. And to do that, investing in healthcare is absolutely essential. Leaving people uninsured is not a solution. We're talking about, the cost, to our budget, again, but not the cost to our economy, not the cost to our healthcare system, or to the individuals who would lose that care and who need to be healthy in order to work. It is a prerequisite to work that you are healthy and able to contribute and, be a productive worker. And so for all of those reasons, I just think that these policies are short-sighted and we're not really meeting the needs of either our, Kentuckians or our economy.
Thanks, Emily. One of the criticisms of the work requirements from the all sides, not just the left, is that many folks receiving Medicaid, particularly through the expansion, already are working. They're just working at low-wage jobs or jobs that don't carry health coverage, or they're cobbling together part-time work. In fact, the noted liberal Josh Hawley recently did an op-ed in the New York Times, which surprised a lot of people, calling Medicaid the new health plan for the working poor, and are warning Republicans not to cut into it too deeply because it would basically cut into the base that supports the Republican Party right now. Given that, I wonder if people are working, why do we need work requirements for Medicaid? Emily?
It's a good question. We don't need work requirements for Medicaid. And in fact, work requirements are not really meeting the goal of the Medicaid program, which is to make sure that people have health insurance coverage and access to care in order to maintain and improve their health. And work reporting requirements, while I understand and agree with the goal that we want people to be healthy enough to work, we want people to be able to contribute to our economy in those ways, requirements are just not the way to go about it, because it's not about work. It's about paperwork. It's about reporting, and reporting more information more frequently and having more opportunities for people to fall through the cracks. So what we've seen in states like Arkansas that have actually implemented work reporting requirements for a short period of time before they were stopped in court was that people who were meeting those requirements were unable to successfully report, or didn't know that that there was a new requirement, didn't know that reporting was required for them to stay enrolled. Many tried reporting on the online system, and for one reason or another, it didn't work for them. The online system actually had hours of operation in which, for whatever reason, still makes no sense to me, you couldn't do it in the evening. It was as if you were, having business hours for going in, logging in, and logging your hours. A lot of people have issues with Wi-Fi and other connectivity literacy issues. And what we found was people who were working or were caregivers or disabled, had an illness, were students, were losing their coverage because of those paperwork barriers. We were anticipating the same here in Kentucky when Governor Bevin rolled out his Kentucky health plan, which was largely based around work reporting requirements. The estimate was that 100,000 Kentuckians would lose coverage. And yet our data shows that 96% of Kentuckians of working age with Medicaid coverage, they are working full-time or part-time. They're students, they're caregivers, they're retired, they're disabled, or they have an illness that prevents them from working. But that's 96%. 2% are actively looking for work. So now we're at 98%. The remaining 2%, we don't know why they're not in the workforce. We just don't have a response from those 2% to know what the reason is. But any of our policies should be targeted to the individuals who actually need some additional support and resources in order to join the workforce, to get a better job, to get maybe more consistent work. So many people with Medicaid who are working have jobs that maybe it's multiple part-time jobs, jobs with fluctuating hours. You've probably heard the term just-in-time scheduling, where people's hours can be changed at a moment's notice, from one week to the next. It's really hard to know how to, prepare for your week, let alone what you're going to report to the government at the end of the month. People with seasonal labor or, who are self-employed have a much harder time with these reporting requirements because it's harder to document something. But The good news is that the state already has income information. It's required when you apply for Medicaid that you include your income. And they, for the most part, people who are being paid by an employer, and that information is being reported to the IRS, there's already a reporting source for that. People are reporting their income. And so we shouldn't be asking for information that we already have, number one. And number two, we really need to focus on, what supports families need in order to be in the workforce or to get that better job. And the number one resource is childcare. Number two is probably transportation for most folks. So that's where we should be focusing our policy solutions.
Jim?
So, a lot there, thank you. Don't we want fewer people on Medicaid? I think that should be the goal. Fewer people on Medicaid means that more people are in the private workforce, are getting coverage from employers, are independent, are experiencing the dignity of work and of effort. If everybody pretty much is working in the Medicaid, that's receiving Medicaid benefits now, like I've heard, that it's a very small percentage that aren't, then what's the problem with implementing a program that gets the rest of those folks onto an employer's payroll and off of the taxpayer's benefit plan? And I guess I'm for care, but when I look at Kentucky's health numbers, I mean, America's health rankings, Kentucky is ranked 41st in the nation in overall health. We hear a lot of these arguments when the Affordable Care Act, so-called Affordable Care Act, allowed governors to expand Medicaid eligibility, which Governor Steve Beshear did here. And we heard a lot of these arguments that people will not get care. They will not be able to get access to health care. But our numbers haven't budged. Our health indicators have not improved, certainly not to justify the kinds of billions of dollars investment that we've made in this. So I'm for care, and I think people are going to get better care if they're working for an employer who provides employer-provided insurance, or they get their own private insurance. Again, Medicaid was not meant to be a destination. It was meant to be a safety net. I'm for that. But the problem is we have people pushing for long-term Medicaid recipients to continue to receive benefits without working. Concerning the rural hospitals that you mentioned earlier, and I know this has been an issue that's come up a lot, there's a lot of reasons why rural hospitals are facing challenges in many places. But one of those I found was this payment review process, this payment process whereby, because the federal government reimburses Kentucky for 70 or 90% of its Medicaid expenses, that hospitals are being charged more for care so that the state can get an increase in Medicaid funding. That's costing everybody. That's a costly program. And I think those kinds of things also need to be looked at. And I think a Medicaid oversight and advisory panel would be helpful with that. Two things about the work requirement. Other things, the Congressional Budget Office is saying that estimated work requirements could save $60 to $80 billion over a decade by just reducing enrollment among non-working able-bodied adults. And polling has showed that this is very popular. And I think it's popular with reasonable Kentuckians that they would expect people who could work to do so in order to receive benefits.
Now, if I could respond to a few of those things.
We got a lot of questions coming in.
Okay. I primarily just want to respond to the idea that work reporting requirements would actually result in fewer people having Medicaid because they now have employer-sponsored health insurance, or they're able to afford health insurance. Because what we see is that, if you have a work reporting requirement and you're already working, and the issue is documentation and falling through the cracks, that's not going to result in you having a higher paying job. So we're talking about people who are either working in low income jobs, or they have a reason that they're not working because they're a caregiver, because they're disabled, or they're ill, or they're a student. These work reporting requirements don't produce better paying jobs. We need to work on a whole lot of things in Kentucky to have higher paying jobs. We could look at things like increasing our minimum wage or any other requirements on employers to provide health insurance even to those low wage workers. But work reporting requirements in the Medicaid program are not going to solve that. And so I think we have to really focus on, again, what the goal is, which is to make sure that low-income Kentuckians have access to care so that they can be healthy enough to work. If they happen to be working in a low-income job, they're going to continue to be eligible for Medicaid. But these are jobs that we want filled. They serve a purpose. They're important. And while they're not making a lot of money, they are participating in the workforce. And so I think we need to be mindful of that. But also the CBO, the Congressional Budget Office, has estimated that the plan that is currently being debated in Energy and Commerce Committee in the House is estimated to reduce Medicaid enrollment by 8.6 million over a 10-year period, and that is primarily due to the work reporting requirements. And so if you look at, who should already be satisfying those requirements or eligible for an exemption because of an illness, because of caregiving, that sort of thing, we shouldn't see that many losses. It's the paperwork.
You all have mentioned the employment and the idea, and Jim mentioned about the dignity of work and getting folks into the work community. What does Kentucky need to do to get people into jobs that pay enough that they're above the Medicaid threshold and have access to employer health insurance? And if we could keep comments a little briefer, sorry, we got a lot of questions here.
I'll be brief. I think our legislature has taken some important steps to doing that. Since Right to Work was passed here, which heavy manufacturing industries really like, they've come here. We've exploded along our borders. 40% of our population in Kentucky live on a border with another state. So by implementing some of these policies, reducing the individual income tax rate, by the way, not telling employers they have to pay more for a minimum wage job that may not be worth that to their company, but allowing employers to determine what a job is worth to their efforts, I think that's important too. So we need to reduce the amount of regulation. One of the things we do need to do to increase jobs quickly is, related to healthcare, is get rid of the certificate of need requirements. If we had that in our rural areas, we would see different, innovative, more creative approaches to providing healthcare. That should be the goal. Not keeping a hospital open, not keeping a jobs program going, but ensuring that people in those areas have care. And I'm for that. And I think some of these things you mentioned can be addressed. Paperwork issues, I agree. It's a bureaucracy, and it's not going to be perfect. Medicaid is too big to be perfect. But I do think those things, we should give attention to those, but still encourage people to work and do better for themselves.
We can absolutely agree on certificate of need being a real hindrance, and I think that that's important. But to your question, Debbie, I think the Affordable Care Act, also includes marketplace plans with subsidies, and that's been really popular here in Kentucky, very important. We've had our second largest enrollment in the 10 years that we've had Connect, or maybe 11 at this point. In any case, second largest enrollment, higher subsidies because of some enhanced subsidies that were passed during COVID, and those are about to expire. So for any individual who is, potentially losing Medicaid coverage, whether it's because their income goes just above the threshold, which is 138% at the federal poverty level, very low, about $20,000 a year per person, or if it's because of a work reporting requirement and somehow they fall through the cracks and lose their coverage, they're not going to have an affordable option to purchase health insurance on their own. And, to Jim's point, the employer may not be offering it and may not be paying them enough that they can purchase something on the individual market. And so I think that we have to consider that we're not only making cuts to Medicaid or, considering cuts to Medicaid that would be really, really severe. At the same time, we're losing some of these affordable options on the marketplace.
I think employers who want a workforce will do what they need to do to offer the benefits that are needed. We're seeing that happen. That's the great thing about having a competitive labor workforce. And by the way, Kentucky has one of the lowest workforce participation rates in the country. I think we need to do everything we can to get people into those jobs. Thank you.
A question about fraud related. It mentions that a certain entity in Kentucky now is under investigation for fraud, for healthcare fraud in the behavioral health addiction arena. Do you think is there widespread fraud in Medicaid? If so, where is it, and what could Kentucky do about it?
You know, there is provider fraud. Sometimes there's managed care fraud. There's very little fraud for individuals. Individuals aren't able to take advantage of their Medicaid coverage for non-medical purposes. You can't take your Medicaid card and use it to purchase groceries or go on a vacation. Very few people are getting a root canal for the fun of it. You know, this is not something that people are saying, you know, I want to get extra health care for no reason. Most of the time, we're encouraging people not to delay getting that preventive checkup, not to, you know, make sure you go see your doctor at least once a year, get that colonoscopy. It's really hard for us to get people to get even the basic level of care that we want them to get before they end up, you know, having a critical condition or an emergency. And that's where we should focus our time. But I really think that the fraud is, you know, mostly in the provider arena, and it's not widespread. Most of our providers are really doing everything they can to be good stewards of these dollars and to serve this Medicaid population and our communities. But that's where we need to focus our efforts. And again, none of these proposals do that.
We heard that with the pension system too. There's not really a big problem here. We shouldn't be concerned about this. And then we established the Public Pension Oversight Board, and we found out, and legislators found out, and Kentuckians found out how bad the problem really was and how deep the hole was, and that we had kept digging that hole. I think that's what's going to happen here. We already know of significant fraud with providers who provide for addiction-based services, specific types of services in this space. And I think we need to have light shone brightly on that because, yeah, I agree probably that Medicaid fraud is not on that similar level with individuals, but who pays for this? Who pays for the fraud? It's the taxpayers that pay for that. So we need this Medicaid Oversight and Advisory Board to be aggressive in looking at what fraud is happening and the extent of it. And taxpayers deserve to know what that is and to have somebody looking at that. So I think that's very important. I would disagree in terms of I think there's more fraud than we even know right now.
If just a point of personal privilege here on the Medicaid Oversight Board, I agree it's a great idea. In fact, we used to have one till the General Assembly abolished it by rolling it into another committee. And then I was at a meeting about a year ago where the chairman's like, we need a Medicaid Oversight Committee. I'm like, yeah. So, yeah, I think it does play an important role, and I'm glad they're bringing it back.
On that issue, the heal and the hurt thing again, when the Public Pension Oversight Board started, there was a lot of animosity between that board and the pension systems because you know, the board was in a fact-finding process to find out what was really going on in the system. But once that happened, they became collaborators. And now we've made some good progress. And I see my friend Brent McKim here. We made some good progress, you know, together, working together on common sense legislation, especially for new teachers. I'm with you, Brent. I think that's a great accomplishment for our state. But it took that. So sometimes there's some hurt that has to happen. It's like tough love, you know? Do we really want people dependent on government? Shouldn't our focus be on finding ways that people aren't that and they can still get the care they need? I want people to have care. I want the resources to be there for that. But if we waste them and we don't pay attention to the fraud, they're not going to be available for the people who need them.
I have another question here related. A lot of people don't realize the amazing breadth of Medicaid coverage in Kentucky. It's more than just hospitals and docs. It covers a lot of disability services. It covers waivers for folks in the disability community, such as you've probably heard of the Michelle P. waiver, which provides supports for folks with, it provides a lot of therapies and services for children, mental health treatment, and also covers nursing home care for the majority of adults in nursing home, which is one of the more costly programs. How will changes like this, or if there is a reduction in Medicaid money available in Kentucky, how would that affect these areas? Jim?
Well, I think that's another reason why we need an oversight and advisory board is to look at where we're spending those dollars. And here's a novel idea. Let's find out how we might do it differently. And in the doing it differently, we might do it better and more effectively. And so I think that there are issues going to have to be looked at. But again, I would go back to Medicaid has become so much more than what it was intended to be in the beginning. This is the growth of government program. And so there may have to be some tough decisions. I'm willing to say that today. There may have to be some difficult decisions made, thinking about the long term, though, thinking and making sure that the Medicaid system is there. It's unsustainable. I'm convinced from everything I've read that it's unsustainable or close to that at the current rates we're going. So anything we can do to make it work better, more efficiently, maybe we don't fund nursing home, maybe we have some different approach to that. I think we need to be willing to think differently.
Well, right now, 70% of Kentuckians in nursing homes are covered by Medicaid. So I think that that would be a really hard thing to change. And where the funding comes from, it's still going to come from us ultimately. And it still costs money, no matter how you slice it. But when we, again, think about what's driving cost, with the state budget in particular, Debbie mentioned that $15 billion of the $20 billion budget is federal funding. So we're investing about 25 cents on the dollar when you average all of our different reimbursement rates or match rates with the federal government together. It's a great deal for Kentucky. We shouldn't be giving up on that. Now, yes, it is still a government cost, but again, what the cost of not having this coverage is far greater, and the benefits to our healthcare system, to our economy, to our workforce all outweigh that cost. It's a necessary investment in our health and our well-being and our workforce. But I think as far as the MOAB goes, the Medicaid Oversight and Advisory Board, I really do hope that we have a lot of good conversation, really use the data for decision-making to drive these decisions. But we have to fundamentally agree that there is going to be some cost, that cost is an investment, and that it is just necessary to have some subsidized care for low-income Kentuckians. Whether it's purchasing a plan on the marketplace or something else called a basic health plan that we've advocated for here in Kentucky, all of those are actually subsidized to make them affordable for low-income folks. So whether it's Medicaid or some other subsidized solution, it's going to be subsidized. There's just no way that somebody making $16,000, $17,000, $18,000 a year can afford $300, $400, $500 of premium every month. The numbers just don't add up.
If somebody's able to work and they're not doing so, they should.
I doubt there's any disagreement on that point. Right. So here's a real MIGO question, but I think it's going to be fascinating to hospitals, docs, any nursing homes, anyone out there, and that's the provider tax. And that's a surcharge providers pay in order, I will not get into the weeds, but to recoup more money in Medicaid payments from the federal government, which allows the state to draw down more money. So if Congress changes that, which they're contemplating doing that, do you have any thoughts about the impact on Kentucky's Medicaid program? And should we even have this provider tax, which some have called a loophole? Mm-hmm.
Whether we use a provider tax or we increase, the amount of money that we're drawing down through our state and federal match, we're going to need to have high enough reimbursements that we have providers who are, seeing Medicaid patients and hospitals that are able to operate. So, however we do the math, whatever formulas we come up with, we're going to have to make sure that reimbursement rates are covering cost or close to that. And that's what the Hospital Rate Improvement Program has attempted to do. Now, I'm not a hospital and I'm not going to talk on their behalf, but I do know that, they are getting billions more dollars in funding every year through this program because they're getting the average commercial rate. And that has kept our rural hospitals in particular much more solvent. When you look at a state like Tennessee that has never expanded Medicaid, they have struggled so much with their rural hospitals and in every other way in terms of healthcare access for low-income Tennesseans. But particularly, they have had many, many hospitals close their doors.
I think Tennessee
while-
has the highest rate, doesn't it, of hospital
Yeah.
closures?
And so, as a neighbor, that's a stark contrast. Now, one more thing I'll say, and then I'll turn it over to you, Jim, but that growth that Jim kind of alluded to earlier in our Medicaid budget over the last few years has been driven by the hospital rate improvement program and some other directed payments, as well as increases to the waivers that serve people with disabilities and keep them in the community, which is still much better, much less costly than if they were in an institution. So it's money well spent, but it was all about increasing reimbursements for providers. And the providers will tell you, and again, I'm not a provider, so I'm not speaking for them, but they will tell you that that they're still barely covering costs.
So I think the provider tax, that's the term I was looking for earlier, thank you, Debbie, that's an area that we definitely need to look at in our rural areas. I'm going to say just because a hospital is in a rural area doesn't mean that that's necessarily the best way to provide care for that area. I'm not saying that we shouldn't have care there. I'm saying we should think about how we can do it in a more economical way that's not this ruse where we're increasing the tax that a provider pays because we want to increase the amount of reimbursement from the federal government. I think that what we should be concerned about is the fact that the federal government might not continue to pay 70% or even 90% as they are for some of our patients. What if they said it's going to be 60-40? And there was a debate on House Bill 695 about this, and Senator McDaniel said that would be a brand new expenditure for the state, a single expenditure of over $4 billion. So I don't have all the answers, but I do know that in a true free marketplace, you remove the barriers. We have entrepreneurs. We had some folks in Owensboro who a few years ago, wanted to open their own surgical center. But they couldn't do it because they couldn't get the certificate of need. They went across the river in Indiana and did it. And so those are things we can remove without cost. That doesn't cost us anything. So, and in terms of a cost of a change in a program like the work requirement, there will be some upfront costs. But we have to look at this long term and what the savings are going to be and how they would help ensure that we have coverage for low-income Kentuckians. By the way, I'm for Medicaid covering what it was created to cover, and that is disabled, pregnant women, the truly indigent. I think that needs to be done, but we don't need to be paying for able-bodied adults.
Well, in all fairness, Medicaid was created in 1965, and things have changed a little bit, but I take your point. Yeah. So I have some questions along the line of employer-provided insurance and coverage, and one of the questions is why shouldn't employers be required to provide it, or shouldn't they be required to pay into the system if they're not providing it? And is there a way to incentivize employers to offer insurance so employers, as I think we know the Walmart syndrome, the employees don't go to Medicaid because their wages are too low to pay for health insurance themselves?
A lot of employers also keep hours at a part-time level for some of these low-income workers to avoid having to provide health insurance. That's just common practice. Now, I don't think that we will be successful in getting employers to pay for health insurance, or at least to be mandated to cover health insurance. And I don't think it's actually the best model. It's pretty unique to America, to the United States, that we do it this way, and it's really inefficient. And for individuals, it impedes your ability to be innovative, to be entrepreneurial, to take risk because you're so tied to that employer and to that health insurance and to whatever the network or benefit, plan that they have. And we want people to be innovative. We want people to be entrepreneurial. I think we can agree on that. And so the less it's tied to employers, the better. And it's also just less transparent. People don't understand what the real cost of care is. It hinders other kinds of improvements in like wages and benefits because so much of the cost is going to health insurance, and that increases every year more than inflation. So I really think that a single payer system is the real solution here for us to cover everyone and to do so more cost effectively and with more less administrative burden, and to allow for more of that, just mobility. But that, I also don't see that as a reality in the near future. I think keeping a strong Medicaid safety net is absolutely important.
I would agree with that. I think a safety net is important and needs to happen. But if we waste resources, those resources are not available for that. So we need to make sure that we have that. But you mentioned something about employers not managing the healthcare very well. So do you think that the government would do a better job of that? I mean, I don't think that's the way to go. When you look at our economy is growing here in Kentucky. Our governor said so even, and it's because of a lot of the policies that the legislature has supported that I mentioned earlier. But folks, if you want to get a job, you can. Most employers are offering some kind of health insurance because they need people to work for them. So this is I think the positive aspects of having a competitive labor market is that if you want workers, you have to offer them what they need. And I think that's the answer here, not some top-down government-run system that's bureaucratic and costs taxpayers and doesn't improve our health. So I think there's a big difference in the thinking on that. That's my thinking on it. So thank you.
One question that's come up, and I'm sure folks probably realize it, but a lot of the care provided under Medicaid is through various nonprofit entities. I'm thinking, like I guess the mental health, the comp cares, the federal qualified community health centers, like Volunteers of America here in Louisville. So what would changes or cuts to Medicaid or a reduction in funds mean to organizations like the nonprofits? And I know hospitals are nonprofit, but I think they're kind of in a league by themselves.
That's a good question, Debbie. I think, and I'll jump in here first if that's okay. I think that reducing the dependency on government funding for those entities, I think you'll see some entities that have backed away step up. We've discouraged a lot of input from the private sector in terms of providing for all of these needs, whatever they may be, whether homelessness, whether hunger, whether addiction help, whether even employment help, preparing somebody to get a job, helping somebody get a job. And I think we've discouraged the engagement of the private sector with more government funding. And everybody says, well, the government will take care of it. Medicaid will take care of it. And I think we're missing some real opportunities there, if I can put it that way, to really make a difference. So I think we need to think differently about that.
I don't see private industry lining up to take care of people who are uninsured. There's no money in that. There's only cost. And, philanthropy is not going to be able to do it either. We have to have a tax, base that supports some of these programs. Healthcare is a human right. Everyone needs access to care. It's better for all of us that our neighbors and our coworkers and our family members are healthy. And so we have to start thinking about this as an investment and not just as a cost or a drain. But I really think that, to the point that was made earlier about providers, or to your question, Debbie, it would be devastating for our federally qualified health centers, devastating for the community mental health centers, and for other nonprofits that support Medicaid beneficiaries in these communities, because not only are they, primarily the ones who are the safety net, who are seeing Medicaid beneficiaries, they're also seeing people who are uninsured now. That's already a strain for them. To increase that number further and not have an offset with additional revenue, from the federal government or from the state, it's just simply unsustainable. And so I think looking at the numbers, the estimates, again, of how many people could lose coverage and become uninsured, there is not another solution for an alternative type of insurance or coverage or access to care. So we're only talking about people becoming uninsured and then being kind of on their own to figure it out. But they would end up in the emergency room, or they would go to an FQHC and, be paying out of pocket on a sliding fee scale, the same with a community mental health center, but they only have so much capacity. And whenever they, have no more appointments or they have no more funds to cover that charity care, they're going to have to stop seeing people.
We just wanted to point out here, one thing we didn't mention is on the nonprofits, a big portion, majority of Kentucky's child welfare services are funded through Medicaid, and I'm talking about like St. Joseph Home of the Innocents here in Louisville, Sunrise Services. A lot of that money flows to very costly care of treatment for kids who are like in foster system or are in need of therapies and various medical services. So that would definitely, there could be an impact there as well.
Well, there will be an impact because I think we've created the expectation that this is all going to be funded by government. And I think what we need to do is determine what fits the true need of Medicaid, what the program was actually created for. And when I look at the investment that we've made in this, billions and billions of dollars, and then I look at Kentucky's health rankings, we haven't improved. What has this investment brought us in terms of health outcomes and improvement? I'm for care, not just coverage, not somebody just having a card. When Medicaid expanded here, a lot of people got a card, but I'm confident a lot of people didn't get the care they needed. Now, these other situations, I think Americans are very empathetic and sympathetic to the needs of different populations, and I think there's some things we'll figure out. And maybe we do need to subsidize some of these programs and continue to do that. But we need to be more intentional and more aware of how we're spending those dollars. These are taxpayer dollars, and we should be spending them in a more efficient way.
Well, Jim, you've said that a few times that we haven't improved our health. Our health ranking has improved quite a bit over the past 10 plus years. And there's a lot of research to prove that. The Commonwealth Fund, Harvard, SHADAC, they have all done studies that have looked at, and in addition to the University of Kentucky, University of Louisville, they've all done studies to look at some of the impact of this expanded coverage and access to care. We have seen results for Kentucky that have found more people have a primary care provider, are getting regular care for chronic conditions. Fewer people are skipping prescriptions or whatever their treatment protocol is. Fewer people are using the ER as their usual source of care. Hospitals saw a reduction in their essentially their unpaid charity care, their bad debt of 2/3 after we expanded Medicaid, 2/3. So that's where we get to hospitals being in a much stronger position now. We have fewer preventable hospitalizations, and hospitals recently have seen that they've actually been improving in areas of infections in hospitals as well, or rehospitalizations when people, are released and then end up back in the hospital. They've been seeing good progress there. We've had more people getting preventive screenings for cancer, breast cancer and colorectal cancer in particular. We've seen a huge improvement in early detection and treatment, and people getting treatment for hepatitis C, for diabetes, and going to the dentist and getting, the kind of treatment that they need in order to protect their heart or to improve their diabetes.
So America's health rankings, Kentucky's 41st out of 50 states, so maybe there was.
I think we were 44th.
We've been lower.
Wonderful.
So that's quite a leap.
Wonderful improvement there. But 45th.
We've gone up 8 places.
In terms of areas like chronic disease, life expectancy, Kentucky's ranking in behavioral health is 37th. Actually, we're higher there than other places. So, but I think that, again, I think that that's important to look at the outcomes and the return on investment, not just continue funding something because we always have.
And speaking
I
of
want to move on
behavioral
here
health,
because we've got more questions and we're getting close to the end of our hour. Here's a question that's short and to the point, so I'll ask you to keep your answers likewise. What happens to those folks who get the boot if Medicaid services are cut or reduced?
they're uninsured. And, you either, if you have no option but to, fill a prescription to get some treatment for a chronic condition, you will probably have medical debt. And if you're healthy, whenever you lose your insurance, you wait until you have a condition that takes you to the emergency room. But people's health will deteriorate. most individuals will not be able to afford to purchase health insurance.
That's assuming, of course, that these individuals aren't going to go and find a job or get training or go to school or find benefits. By the way, Kentucky had fewer people that came off the Medicaid rolls after COVID than any other state. We added during that time. We had fewer people that came off of those rolls than other states had. I don't see where what we're spending and the investment we're making is producing the returns that we should have. I think we need, at the very least, we could all agree, we need new ideas. We need to look at how dollars are being spent, and we need to allow health entrepreneurship in our rural communities. That will help.
Another quick question here. Why should we not care about able-bodied adults being subsidized by taxpayers for Medicaid coverage?
I think we need to ask ourselves, what is an able-bodied adult? And, you know, when you look at disabilities and illnesses, various reasons that people may struggle with their health, it is not always visible. So I think that substance use disorder is one of those things that, you know, of course, we see some people who are in active addiction and their life is, you know, is a disaster, and their health has deteriorated already. A lot of people are working and struggling with a substance use disorder as well. We wouldn't know it. And so one of the probably biggest improvements that we saw after the Affordable Care Act went into place and we had expanded coverage, we also, for the first time, added substance use disorder treatment as a benefit for all Kentuckians with Medicaid and as an essential health benefit for our marketplace plans. So not only for kids and for pregnant women, but for every person who is eligible. And we saw access to treatment improve, 500%. And we have needed that access to care for, all of the various struggles that we've had with the opioid epidemic and other substance use. And so I think that is one area where, we would see a huge reduction in access to care.
Well, when the Medicaid eligibility was expanded here, we had lots of people who at that time were on private plans who, with that eligibility increase, said, why should I pay for my own insurance when I can receive a handout from the taxpayers? And that's what they did. So I think that able-bodied people are going to find insurance in the private marketplace. The government funding is not intended to fund people who can go to work and who can get benefits. If they cannot do that, then I think Medicaid is for them. But we have to be much more intentional about how we fund this, and we have to know more about it. So, but I think that what happened there with the expansion of Medicaid eligibility really told me that there were a lot of folks who, and I can use the word, if they were incentivized, let's say, that, hey, this journey's not going to continue on Medicaid. You're going to have to find a job, and you're going to have to find insurance. I think that's one of the most humane, compassionate, productive things we can do as a state. That would be my view. So,
Is Medicaid sustainable in its current form?
I think so. I think that it's a matter of our budget priorities. It's a matter of making that investment and having a tax base that can support it. In Kentucky, a challenge of ours is that, our Republican majority is looking at taking our income tax to zero. And I think that a lot of this focus on Medicaid spending is a way of, looking at what we won't have a tax base for in the future. But that's a choice we make. This is important. This is something that I think I know Kentuckians support. The polling data for Medicaid is very high. And in fact, when people are polled on Medicaid and their support for it, they want the same, if not more, spending on Medicaid because they see how valuable it is.
well, the Congressional Budget Office has said it's unsustainable at its current level. So I'm going to go with what they say. And I'm also going to say I don't want to see this this program in a situation where it's not available. And so we're going to have to make some decisions. And I think that's what's happening right now. Reducing our individual income tax rate is one of the best things we've done for helping people find employment and grow our economy here, because income taxes punish productivity. you work more, you get punished for that. Whereas the model we're moving to, sales and consumption and use taxes, are being used by states that are more competitive than we are, have attracted more economic growth than we have. So we've seen this in action. And so I think it will make our politicians and our legislature be more careful about how they spend our dollars. I think it's going to require that. And so far, we're pretty pleased with what we've seen. So thank you.
Okay, I'm getting the high sign. We're close to the end, so I'm going to go to a lightning round. Ask you to keep your answers to one sentence or less. Does Kentucky have resources it needs to help people obtain skills to be successful in jobs that provide health coverage? Jim?
Yes, but we need to encourage those to be developed and used, and we need to think more about how we can interject that into our policy. I agree.
If we have work reporting requirements and people need additional workforce supports, we don't have at the state level the number of people to provide that assistance. We have some, not enough, and we need more child care subsidies.
Question two.
More spending.
What's one change you would like to make in the program if you had the power to do that? Emily?
I think that the program is strong, and anything we can do to reduce administrative barriers is important. Even with our current program that we have now, paperwork barriers are a problem that end up creating churn where people are on and off coverage. It's hard on providers and is a cost to them, and it's a cost to our state.
And I think moving the able-bodied off Medicaid and making those hard decisions would be what I would do.
Conversely, are there any areas where you think Medicaid access should be increased? Jim?
I don't know of any right now. I think it can be done better, though, in many areas, and needs to be for the benefit of recipients of that benefits.
I think we have 250,000 Kentuckians uninsured today. So we don't have enough access to care for everyone in our state. And whether Medicaid is the solution or not, we do need to have another solution to make sure people have affordable access to care. A basic health plan can be paired with Medicaid so that as people's income increases or decreases, they can move seamlessly between the two. Both are subsidized, but in different ways. And there's some cost sharing in a basic health plan, and I think that is missing.
I think there could be some things done with that, where people, we should encourage them to work. If they're not making enough and they need to go through a transition period, fine. I'm talking about this not being a destination, but being part of the journey.
Have we passed the point of no return in reforming the Kentucky and the United States hybrid system of government-private health plans and sort of the sprawl of the system?
I don't know.
Yeah, we may, even if we have, though, we should continue to look for opportunities to develop competitive models, things that will bring costs down and improve care and improve service. And so we could talk about the big picture, and maybe we have, but I think any opportunity we have, for example, getting rid of regulations, I agree with getting rid of the administrative barriers, but getting rid of certificate of need, getting rid of those things will do a lot to help provide care. That should be the goal.
And I think our time is up, so I'm going to turn it over to our president here to wrap things up.
Thank you all so much, Emily, Jim, Debbie. Appreciate you all coming and being with us today. All right, and that is the end of today's program. Mark your calendars, June 11th. That'll be our next program. Stay tuned for the topic. And again, thank you to our speakers and our moderator.